Hello, Nystra recreational therapists. Welcome to this virtual session, Trauma-Informed Recreational Therapy Clinical Supervision. And I'm Stephen Lewis, and I will be guiding you through this today. So our three main objectives are to review the broad concepts of clinical supervision, make sure we're all on the same page with that, and also know some of the possibilities with clinical supervision in recreational therapy. Explore principles of trauma-informed care. Just like clinical supervision, this may be something that you've hopefully at least been exposed to, if not already actively incorporating this into your agency and recreational therapy practice. And then at the end, we'll apply trauma-informed principles to RT clinical supervision. And so, in terms of who this is an appropriate session for, I would say anybody at any stage. Now, if you're an expert at trauma-informed clinical supervision, you may not get much out of this because this is going to be more of an overview introduction, so people will be able to identify what areas they would like to go deeper into. But it's really putting all those pieces together and just thinking about how RT clinical supervision can look through a trauma-informed lens. Now, I'll give you just a little bit of information about my background, but mainly just talking about where I have really experienced clinical supervision as an issue and what my experience is with that. So I was a non-traditional student. I was a little bit older going back for my bachelor's degree. I was in my mid-20s, I guess, when I started back to school, late 20s, when I graduated with my bachelor's at Florida State University. Um, I went straight into my master's after my internship. My internship was at Warm Springs Institute for Physical Rehabilitation in Warm Springs, Georgia. And so in physical rehab, I was mainly focusing on people recovering from strokes, as well as some other conditions that they would come there for. Brain injury was really separate in terms of the unit, but I did get to do some co-treats and some recreational therapy on the brain injury unit as well. This was really my first big experience with clinical supervision. For my practicum experiences, I would say at the most I received weak clinical supervision from the agencies I was at, although the last one I did, which was actually an extra one in mental health, I did receive much better supervision. And I believe that's just because mental health sites are more likely to be already practicing clinical supervision. Um, but so I received my master's in Recreation and Leisure Services Administration and moved to Bloomington, Indiana, and almost immediately after moving became the supervisor of a partial hospitalization program for adults on the schizophrenia spectrum. So this was very different from me. I was probably a supervisor before I was ready. I think that's often the case, but the opportunity was there and I took it. What I realized very quickly, though, was I still was working off of being a conceptual recreational therapist in mental health. I felt like I had gotten up to speed, just like the baseline with physical rehab when I was on my internship, but this was a little bit different. While there's overlaps, of course, each kind of setting is going to be a little bit different. So, one, I really needed to gear up still in terms of understanding the population. But at the same time, I was providing supervision to interns, other recreational therapists, non-RT staff, part-time staff, students, different levels. I had student nurses come through. It was interdisciplinary. I would supervise caseworkers sometimes. So it was a little bit overwhelming, and I was making calls that I wasn't always sure about. So I started talking to my supervisor more about receiving clinical supervision. He was a social worker and was a little bit resistant to this at the time, which is surprising since clinical supervision is so strong in social work. I don't think he really understood the necessity, which I should maybe take as a compliment that he was appraising me high enough not to need this. However, I finally convinced him to, meet with me weekly. And aside from the business stuff, like we had to talk about budgets and staffing issues and things like that, I wanted to do it through the clinical supervision lens because I wanted to be a good supervisor. So that's really when I started learning about the process, and I learned a lot from him, as well as other friends there, psychologists, caseworkers who've been doing this for a long time, and other therapists in terms of like learning about clinical supervision. I really didn't know much about it from my education at Florida State University, other than my internship. So then when I left the Center for Behavioral Health in Indiana, I actually moved to Invercargill, New Zealand, at the bottom of the South Island. And I was able to teach therapeutic recreation at the time for a year and a half at the Southern Institute of Technology. Really, really loved that experience. But one of the neat things about it was our students were going out into the community in agencies sometimes that we wouldn't necessarily think about recreational therapy being in, but all of these disability service organizations, which were actually pretty plentiful and well organized, were very welcoming of us in their settings. However, they didn't have recreational therapists to provide clinical supervision. Usually, we had a few graduates, including some who went to the States for their internship and became certified and brought that back to New Zealand. But I was supervising students in a lot of non-traditional kinds of sites, including public health settings, traditional Maori practices, kaupapa Maori services, which were very holistic, hospice services, and other disability service provision agencies. And so I really became a lot more skilled. I was also doing a lot of research on clinical supervision during this time in terms of providing the best feedback that I could to my students. And I even had one who I was able to provide clinical supervision through their internship. Coming back to the United States, moved back to Bloomington, Indiana to pursue my PhD at Indiana University. I was a visiting lecturer. And I didn't do much clinical supervision at that point. When I moved to La Crosse, Wisconsin, as an assistant professor, I did provide clinical supervision to students that are on fieldwork experiences, but also through partnerships that we created. We had a program, or I developed a program with some graduate students that were entry-level graduate students in therapeutic recreation. And we were working with an agency with adults with intellectual and developmental disabilities within the community. And we went weekly to provide programming. And that night, we would meet as a class, and I would be providing clinical supervision. I was using a strengths-based, solutions-focused model at the time. But then coming to Clemson University in 2014, I was the fieldwork coordinator for a while, so I did some level of supervision, but it was mainly administrative supervision, while the sites were tasked with more of the clinical supervision. However, I did work with students in preceptorship in the community. I especially worked at one assisted living facility for older adults. And I provide direct supervision there. And during the pandemic, we had to have some alternative experiences for students. And we had an online group with adults who had traumatic brain injuries. And I provided clinical supervision and leadership in that role, as well as some other roles locally. So also, I was the instructor of record for the management class in recreational therapy, a graduate level course, when we had our active separate curriculum for graduate students in recreational therapy. And so clinical supervision was the main focus and the thing that I felt like the students got the most out of. So this presentation today actually has its roots in that course where I was teaching about different aspects of clinical supervision. So, what to expect in this session? We will address the three objectives that I can promise you. But I also want to mention like content expectations. I don't want to call it a trigger warning because I think that term has become a little bit overused. And I'm not warning you, I just want to let you know. This is obviously going to include a discussion on trauma. I'm not going to be talking about specific traumatic experiences or even the case study that we have at the end is very general and non-specific. I will be mentioning some broad causes of trauma and trauma-related issues. And so just know that that'll come up. And I think that the time when that comes up will be very logical when I'm defining trauma and talking about trauma-informed care principles. Um, but if you do find some part of this presentation to be less safe, I really would love to hear from you, just because that's something that I do value and care a lot about in my presentations. But to get the most out of this presentation, one, actually focus on the content slide by slide. But there's going to be some times where you see an icon for you to pause and you'll hear my instructions and where I want you to brainstorm or process or list some things out. I know it's so easy just to kind of go along with it or make some mental notes, but if you want to get the most out of this, really pause the presentation, list the things out, try to answer the quiz questions, whatever it is, and then compare your answers with how I process it. You can always, if you're like, oh, wait a minute, I can't name two different items or whatever the question's asking for, is completely appropriate to go back and review. Go back to the part of the presentation where I'm covering that, rewind, and then come back to the questions. You're not having to submit these, but I am asking you to take it seriously so you can see what did you actually get out of this. So you can see that pause icon right in the middle of the screen. Um, and so we're going to start with, I want you to think about what does the term clinical supervision mean to you? Try to come up with an actual definition, just like a one sentence definition of what you think clinical supervision is. But also think about maybe just bullet point out some of your experiences with it, whether it's providing clinical supervision to other people or receiving clinical supervision as a student or a professional. So those are the two things I want you to think about. So please go ahead and pause this recording and take just a couple of minutes to write these things down. No more than 5 minutes, though. All right, welcome back. One thing I'll say with the defining clinical supervision, there's a lot of different ways that we could, kind of frame what clinical supervision is. But often we hear this term kind of mixed in with administrative supervision, managerial roles, like all different aspects. And you may be wearing all these different hats, but we want to focus specifically on clinical supervision and the scope that that contains. We're really talking about clinical supervision as a framework to support those who are providing clinical services. In this case, we're talking about supporting our recreational therapy students, maybe they're practicum students or interns, especially with internship, we should be providing really robust clinical supervision, or this may be recreational therapists within your staff. That said, there's an asterisk there. You may be providing clinical supervision to people from other professions or non-professional backgrounds who are providing services to your clients. And so that supervision is all going to look a little bit different depending on the scope of practice of the individual you're providing supervision for. But again, this is about supporting growth, goal achievement with those working with you. For this presentation, we're talking specifically about recreational therapists who are receiving clinical supervision. Now, clinical supervision, the focus of it can change. While we're talking about being the best therapist that we can be, what does that mean? Where are we starting from? We have to have clear goals so that we know what we're working towards, so that the supervisor can shape the supervision process and any related activities or assignments towards reaching those clear goals. Now, The clinical supervisor, as the administrative supervisor, may have also conducted a performance review, or the supervisee may have gotten a performance review from somebody else. That could be the starting point of a discussion of shaping goals and objectives for clinical supervision on the areas they want to improve. Or it may be something that the supervisee says, hey, I don't know much about mindfulness, and now I have a lot of activities where I'm supposed to be using that. I need help in terms of shaping my growth around mindfulness-based interventions. And so that's a good goal. Or it may be broader in terms of just like interpersonal communication. It may be about managing outside stress within the workplace. That's something that we'll talk about, is like sometimes these personal life things can also be appropriate within clinical supervision, but with limits. But this could be about ongoing development. Maybe you're an advanced therapist and you want to become even more advanced. Um, Clinical supervision allows helpful input from an advanced practice clinician. I say usually. Hopefully, if you're receiving clinical supervision, you're receiving it from somebody with more experience than you that has a lot of experience with clinical supervision, but that's not always the case and not always possible. And we'll see with the models even that there's some models where you may be working with a peer and providing supervision to each other. But in most of these scenarios, I'm going to be talking about it as something where you're working with an experienced clinical supervisor, or you are the more experienced clinical supervisor. Clinical supervision should be authentically collaborative. This is not a top-down process. This is a negotiation of development. It's time intensive, but you may meet with one of your rec therapists or meet with each member of your team every week or every other week for a limited time to talk about progress towards goals or feedback that you have about their goals. But it should be authentically collaborative, and there should be a mutual discussion about it. And dependent on perceived need for supervision. If you have a staff member who just really does not feel like they're going to benefit from clinical supervision, they're probably not going to, and that may not be ideal. That may not be part of the culture and something you need to work out, negotiate with that person. But really, we really want to buy into the clinician's strengths, but also think about like their perceived reality on the job, and really think about what is the most salient to them in terms of completing their job duties and also personally important to them. And so, like I said, administrative and clinical supervision, they're often overlapping within our field, especially. We may have very limited RT staff, or you may be providing or receiving clinical supervision from somebody from a different discipline. But those administrative things, the duties we have to do every day, the checklist, the feedback forms, the write-ups, for being late or whatever it is, those are different than clinical supervision. Those are more administrative side things, the managerial role. So clinical supervision, we're not going to start off the clinical supervision meeting with, okay, so I've noticed you've been late. You got written up again. You do understand this is your last warning or whatever it is. No, we want to talk about, okay, where did we leave off? What are the goals that we're going to be working on this week? Let's talk about how you can grow as a recreational therapist and be the best recreational therapist that you can be within this agency. They need to feel safe within the clinical supervision space, safe to express emotions, to be disappointed, to not have to focus on all the things that they're doing wrong all the time, but it's more holistic. So we know that clinical supervision, while it's not one of those background terms, it really does still cover all those. Anything that's part of your job, part of your administrative roles as a recreational therapist, also is going to impact you as a clinician. So really anything within the job setting as well as outside of the job setting is fair game for clinical supervision conversations. But as we'll discuss, the clinical supervisor is not a counselor, is not there to pretend to be one either. So we're at our next pause point. what makes a good supervisor? I know that's terrible using the word good or bad, but what makes a strong clinical supervisor? And think about your personal experiences or anything that you've read on the topic. But when you've received clinical supervision, usually when we're a recipient of it, we can identify what we think was a really good experience or a really bad experience or kind of a neutral experience. And a lot of what I really aspired to was based on the bad experiences I had with clinical supervision. I didn't want to emulate those. So, what could I do to be a better supervisor myself? And that's something I worked with my supervisor on. But go ahead and I want you to list out, take like 2 to 3 minutes just to list out everything you can think of in terms of what you think makes a good supervisor. Okay, and welcome back. Um, we're going to go over a list. Now, this is not an all-comprehensive list. This is a list that I've made, these next two slides, from combined readings and research that I've looked at on the topic for a while. Um, but let's just go through these. The good clinical supervisor should be skilled and knowledgeable. They should be able to understand the RT scope of practice, our standards of practice, what RT looks like within that specific context of the workplace. And they should have experience doing these things that you're expected to do if they're going to help shape your growth and development. A good supervisor should be trauma informed, which we'll explain, unpack a little bit when we get to trauma informed principles. Um, they should be a strong communicator too. That doesn't mean that a good clinical supervisor isn't shy or quiet sometimes or a lot of other things. There's not one way to be a strong communicator, but they are in tune with social skills and interpersonal skills. Transparent, they're flexible, able to adapt to change. We know a week, a lot can happen. So the person coming to a meeting for clinical supervision may have completely new needs or things could have shifted a lot since the last meeting. A good supervisor should be a good coach and mentor. And coach is, I really like that word a lot because we are trying to be facilitators with the rec therapist that we're providing clinical supervision to. We're not telling them, directing them. We may give them options, but really this is their journey and it needs to be personalized to them. So we're going to help shape things and be a good mentor along the way. If we're a good supervisor, we're modeling the best practices. We're not telling the rec therapist, this is appropriate trauma-informed communication, and then doing the opposite when we're communicating with people. We want to exemplify the expected behaviors on that job. Good clinical supervisor is open to feedback on themselves, on the clinical supervision they provide. We may not be resonating with the recreational therapist we're working with because of maybe our teaching style or our personality, or maybe because of some difference we have with that person in terms of demographics or anything like that. But we really need to be approachable. We need to think about like our attending behaviors, but applying those to this professional setting with our recreational therapists. Also, we can identify teachable moments. I think this is a really good part of not only a clinical supervisor, but a therapist of any kind is identifying moments that come up naturally as, okay, you said this or you did this. Let's build off of this if you're comfortable. This is a great teachable moment on that topic. We support and encourage staff development. We're fair, forward thinkers, active listeners. There's that communication again. Address difficult situations in a timely manner. Supervision isn't always fun and easy. It can be really difficult sometimes. I remember one rec therapist I worked with that I found clinical supervision with them especially challenging, but it became the most rewarding too once we were able to work through those things. And at first I was a little bit passive and thought, well, maybe this will just work itself out, but that was the wrong approach. That just lets kind of unexpected behaviors take root and undermine the culture of your clinical supervision sessions. You understand supervisees' strengths and opportunities to grow, and we really should be as strengths focused as possible. We know strengths based approaches, the benefits of those, and we know that if we're working with whether it's a client or a recreational therapist, when we focus on their strengths, they're going to continue to build those strengths even more. And become stronger in those ways. But we also have to be able to identify these opportunities for growth. Now, while we're very positive and strengths focused, of course, if a supervisee does something or suggests that they're going to do something that's unsafe or contraindicated for our clients, we have to be very direct about that too. It's not just a processing, okay, well, why don't you try that? We have to stop that. But we're really looking at those strengths and opportunities for growth. And we're always catching those expected behaviors and providing recognition for accomplishments. This does not have to mean a trophy. This can just mean you did a great job with this, or you told me earlier you were struggling with de-escalating, verbal de-escalation, but I just saw you use that with Chuck in such a positive and impactful way. That was really great. Just making sure we're catching those moments of growth and what that person wants to see in themselves. So now this comes from one of Dave Austin's chapters, major roles of clinical supervisors, and he listed out teaching, counselor, and consultant. And yes, we may be teaching something. Maybe it's a new skill, maybe it's a modality that our supervisee wants to learn. Maybe it is the NCTRC competencies to an intern, but we do have that teacher hat that we wear sometimes based on the goals of clinical supervision. Now, counselor, I understand where this term came from, but really this is more appropriately like a coach, in my opinion, because we're not ever being a counselor. If somebody's talking about their failing relationship at home, that may be appropriate in terms of how does this impact your job, and what are some ways we can do to lessen the way it impacts your job. But also we would be, as their coach, we would not be telling them what they should do with their relationship, but we would be making them aware of maybe our employment assistant programs, or counseling services available through the agency, or whatever it is, making sure we're channeling them to the types of supports that they need for that, and being encouraging about them receiving other types of supports, but making it clear that we have our limits in terms of what we can do, and being very careful about offering advice outside of our professional scope of practice there. But we're also a consultant. Our supervisees come to us. They may bring a challenging case or issue or something that they've already done, and they're going over it with you to talk about how could I do this better next time. Or they're trying to network with somebody who has expertise in an area that you don't have resources for. So you can be a consultant that helps with that as well. But we do wear different hats as a clinical supervisor. We just have to remember what the limitations of those are. Now, think about what kinds of clinical supervision you're familiar with. I'm not going to go over each one of those, but what we often find is if you work for an agency, for instance, that really embraces cognitive behavioral therapy approaches in their treatment, often clinical supervision is often a cognitive behavioral model. So if there's a specific like theoretical framework that you're operating in within your healthcare or social service agency on the regular, you should look into, is there a type of clinical supervision that also utilizes that same type of framework? Like if you're in an addictions recovery, substance use recovery type of agency, there's often specific models of supervision that go along with that. And actually, that's one of the forms that really I usually can count on to have trauma-informed principles woven in as well. But a lot of places are doing more pragmatic, just kind of mix and match of what's working, what can we do to address the needs right now. But unfortunately, research also shows in our field, we don't have adequate culture from the education level up in terms of clinical supervision. So it's something that we need to do more of. There are some key people in our field that are doing some really great work in advancing this topic. but more work needs to be done, both within the individual agency level um, focus as well as just our field in general. In terms of clinical supervision formats, there's different ways this could take place. I've mentioned some one-on-one formats. When I had clinical supervision with my supervisor, that was a one-on-one format. However, at the same time, we had our team meetings and we did have group supervision. It doesn't mean that they're going to go around to every professional in there and ask them to talk about every case, but sometimes we would bring cases to the team meeting. And the people in charge, one was my direct supervisor, the other was the residential supervisor. We would often have the psychiatrist in there for our team. Um, but they would often refer, like, is there somebody else who's had this experience before that can help them with this? And people would brainstorm ideas, talk about what worked, what to watch out for, but also sometimes the leaders with more experience would process. And we would do this in the group format so that other caseworkers, other recreational therapists, other professionals could learn from this experience, especially since we shared clients. And I provide one-on-one supervision to my rec therapist as well as group supervision to my whole program staff. Peer supervision is where I might find somebody who's doing the same thing as me within the agency. Sometimes supervision it takes place outside of the agency. That's a little bit trickier. We don't have as much of a culture for that within recreational therapy, but something you can look into. But I've had past students before, graduates, who were out in the field and had peer supervisors because they didn't have a leader who was willing or skilled in clinical supervision. They weren't getting what they needed, so they needed somebody to debrief who understood their area of practice and things like that. Supervision can also be live. That's really all I have experience with personally. But we know of instances where they may record somebody leading a session and then play it back and talk about it in a supervision meeting. Or it could be something like case presentations, like I mentioned before, where people are bringing up a case. It may be a new client. It may be a client that's hit kind of a challenge in terms of meeting their goals, but they're bringing the case in for supervision for some feedback. The payoff for supervision, there's a lot of benefits, and research definitely shows this, especially in areas like counseling and other therapy, psychology, where clinical supervision has a longer history. Social work is another field similar to ours in terms of the needs for clinical supervision, the benefits, but they're doing things differently than we are, of course. But we know that it can, if clinical supervision is done in the correct way, it can enhance quality and safety of services. It enhances professional accountability because we're talking about what we're doing, we're striving to be better. It's developing clinical competence, not just of the supervisees, but also the supervisors. We have to continue making sure that we're attending workshops and sessions so we're providing the most up-to-date information with our rec therapists. It increases job satisfaction, staff retention, and staff productivity, evidence-based rationale for why we should do this. It does take a lot of time and there are costs to an agency, but the payout can be just as good, if not better in some ways, while also protecting the wellness of your staff. Increases self-awareness, confidence, morale, and feelings of support. And when clinical supervision, the more it's done, the more it develops a culture of clinical supervision and best practices within your agency. One thing I found in the program where I started providing clinical supervision was that RTs were reluctant to it at first because it wasn't the culture. They could talk about clients with comfort, they could talk about group structure comfortably and planning for events, but when they start talking about their own personal performance, their skills, what they need to improve at or want to improve at, and talk about mistakes that they made, that was really, really challenging until we got into the habit of doing it and it became kind of second nature. And I'll just touch on, my suggestion is to research some clinical supervision contracts. I think that being formal in a clinical supervision meeting can be so beneficial. It can enhance safety and clarity of what to expect. But there are contracts in terms of like what the clinical supervisor expects out of the clinical supervisee, as well as the other way around. So we know what the expected behaviors are, and if one part of that party isn't meeting their end, the other person can say, okay, originally we had this agreement, and now we've moved away from it. Can we please discuss this? Can we move towards this, or do we need to edit our original agreement, or do I need to find a different supervisee or supervisor in this setting? So just know there are templates out there for contracts, and it can be, and I'm talking beyond legality, just in terms of productivity in your clinical supervision relationship and making sure we're clear on our expectations. This can be very helpful. And if we're thinking about providing clinical supervision to an intern, now it's going to be a little bit different, right, than if we're providing clinical supervision to a recreational therapist, because this is somebody who just has a lot of concepts, little tiny bits of exposure and experience, but needs to get up to those minimum competencies of a rec therapist. But we have to remember, like, it's so easy to tell an intern what they are doing wrong or what they need to do better or what they need to learn and pick up. But it's not just about feedback for improvement, and validation of good work. We want to do those things, but we really want to work with them on collaborative goals. Okay, the intern, of course, wants to have an A. They want to get done with this. They want to become a CTRS as soon as possible. But what do they want to get out of this experience? And sometimes it's hard for them to articulate that. So that might be the start of your clinical supervision journey with them. Outside of, okay, what competencies have you been working on? What questions do you have? How are you doing with that? But what other goals do you have in terms of being that recreational therapist that you want to be? And we want them to develop to the point of being independent at the base level of recreational therapy. Um, Now, independence, I think we overuse that word. We should say of professional, healthy interdependence, because they're still working with a whole team and are going to need lots of support and resources and collaboration along the way. In terms of professional level clinical supervision, we want, like I said before, we really want to be as strengths focused as possible and continue developing those strengths. We do think there'll be overflow into other areas, but also because if you are already good at de-escalating and you can become the expert at de-escalating, that could be really significant within your setting. Now, we could also be addressing deficits, growth opportunities. The person has a goal of, I'm not good at A, I want to be more like B. And so we're doing that through a series of interventions and working together and processing homework, whatever it is that we might need to do as part of that clinical supervision process. But overall, we want them to advance to the clinical competence of the next level. And what I mean by that is this. So we have somebody who's a novice. That's really more of an intern. And I would say by the time that they're done, if we're going to be realistic about it, an intern, a really good intern, is more of an advanced beginner, or somewhere between that and competent. I think it's really hard to say that an intern is going to be completely competent, maybe at their intern tasks, but I know by the end of my internship, I had a full load of clients, but I still can't say that even though I was doing well with all of my tasks, that I was fully competent and ready to be independent, but I was somewhere in there on the borderline. But when we think about a new recreational therapist, a graduate, a CTRS, they should be at least at that baseline of competency. But at our first clinical supervision sessions are going to really be looking at increasing that competence, deepening that competence, giving them time to settle into all the different roles that are specific to that agency. We also know through research that different recreational therapists, they may have different job titles. They may be utilizing different parts of their scope of practice. Um, and they may be negotiating scope of practice more with other therapists depending on the setting. So there's all these things specific to an agency or a setting that we also need to learn to become competent at recreational therapy within that setting so that we really feel proficient. Um, and when we talk about becoming an expert, there are some good examples of people watching this right now who are just amazing rock star rec therapists and are experts at some things, but there's always something that we can do more of or do better or advance with. The information is always changing, the evidence is always changing. So everybody can benefit from clinical supervision. I don't care how long you've been doing this. I honestly don't know anybody that clinical supervision wouldn't benefit if it was done with the right team of people, the right supervisor matched with the right supervisee. So at any level of where a recreational therapist is, they can advance through proper clinical supervision. All right, so this is the next pause moment. I want you to review. I actually want you to do this. Take time and jot down, how would you define clinical supervision in RT? What are three characteristics of good clinical supervisor in RT? At least two clinical supervision models that I listed. What are two formats of clinical supervision you're most interested in based on what I shared? And what level of CTRS would benefit from clinical supervision? So pause and answer these questions. Okay, so welcome back. Hopefully you were able to um, answer all these comfortably. If not, you can review, rewind, go back in there, and just, to address that last one, which was a little bit of a trick question. Like I just said a minute ago, all levels of recreational therapists could benefit from clinical supervision. But we need to get into this aspect of trauma-informed care. Um, and this is where you'll pause. And there's not many more pauses in here, but what is trauma? How would you define what trauma is, and what do you know about trauma-informed care already? All right, welcome back. Trauma, according to SAMHSA, is an event or circumstance resulting in physical, emotional, and or life-threatening harm that has lasting adverse effects on the individual's mental health, physical health, emotional health, social well-being, and or spiritual health. The three, oh, there's a typo, three E's of trauma, I need another E, are events, experience, and effects. So the event that was the source of the trauma is one thing, but we experience things differently. So our subjective experience of what happened, how did we interpret what was going on? How did we respond to that? That's our experience. But then what are the after effects, if any, maybe lingering symptoms or changes that were experienced after the trauma? So, it's an emotional response. And how we respond varies, and that depends on our biology, on our resilience at a given moment, at other traumas that we have experienced. Um, it really is an intersection of a lot of different things. Also, what kinds of supports we have through this, but you can't ever predict exactly what somebody's trauma response is going to be. Do you want to mention there's primary trauma where we actually directly experience the trauma itself, but also secondary, which is very important to understand within our settings because we need to understand our clients' experiences, but also our clients are at a much higher risk of experiencing trauma. And so, as we're reading through notes, case histories, and hearing clients talk about their stories or how that impacts them, or may be a direct part of why they're in therapy, recreational therapy, we are exposed to this so much that it can actually cause secondary trauma. Um, Immediate responses vary. Often shock and denial are common. And as time goes on after a traumatic event, uh, there's more chance of emotional dysregulation, flashbacks, sleep disturbances, relationship problems, physical symptoms. And again, symptoms vary depending on the individual, including intensity and duration. We often think about post-traumatic stress disorder. That's a specific diagnosis. Sometimes people use it as slang, which we should not. Um, and not everybody who experiences a trauma, even a major trauma, um, develops PTSD. Again, we can't predict who's going to uh, develop that. We can't assume who's going to develop that, although the intensity of the trauma, as well as exposure to multiple traumas, are going to increase somebody's risk of PTSD, which can be really challenging to treat and individualized approach. Usually, a combination of medication and behavioral type therapies are used. And a CTRS might experience trauma just the way that anybody in the general population does, or you may be part of a demographic or identity that is at higher risk. We know that minoritized identities um, are at higher risk of experiencing traumas within our culture, but also work-based trauma. So we may work in a setting where death happens more. Losing clients can definitely be traumatic, especially as we're developing relationships with them. But also, it could be witnessing an act of violence, or if we're working in a correctional setting, or any setting where we might become injured by a client or something related to the workplace. But also that secondary exposure I talked about, where we may be exposed to stories of trauma so much that we are also getting traumatized, and we may start having trauma responses without even knowing what's going on. So clinical supervision can be a good place sometimes to even identifying that this is happening. This is just talking about trauma informed. It can be a program, an organization, or system that's trauma informed. It realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So trauma-informed approaches are really about making sure that or trying to make sure we're not re-traumatizing people through our environments, through our behaviors. We're avoiding that as much as possible just by raising our awareness and developing trauma-informed skills to help avoid these types of situations. And the 6 key principles to trauma-informed care, although you can find some different versions of this sometimes, but this is SAMHSA. And this is talking about like being a trauma-informed clinician, working with clients, assuming that they may have experiencing trauma, they may have experienced trauma, it may have had an impact on them, but we're not going to assume what level or how that might happen, but we're going to try to avoid this re-traumatization. So we're embracing these principles of safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and recognizing cultural, historical, and gender issues as significant to the trauma response and trauma recovery. And so I'm not going to go deeply into these in terms of trauma-informed care um, just because of time, but I feel like these are pretty straightforward, but you can also, this is something I highly encourage you to go to the SAMHSA or other resources to go deeper into this, or looking within your education or your agency's information on trauma-informed approaches. Seeing how we provide trauma-informed care to clients. This is not trauma-focused care. This is not about treating the trauma. It's about being informed that this may be relevant as context, a backdrop to the services we provide. But what I'm going to do is I'm going to apply how each of these principles might look in terms of trauma-informed recreational therapy, specifically trauma-informed clinical supervision in recreational therapy. So starting with the first one, safety. As a clinical supervisor, I want to make sure that I am addressing physical and psychological safety, that my supervisee, my recreational therapist, feels comfortable and safe coming to me for clinical supervision. The rec therapist works within a safe setting, perceives sense of safety, and so we'll be working with them on any issues related to that. Interpersonal interactions with the RTs. The clinical supervisor promotes a sense of safety. The clinical supervisor understands safety as defined by the supervisee. We're not going to question just because we don't think that something they say sounds unsafe or doesn't feel unsafe to us, doesn't we're not going to discount how it feels to them. So we need to really listen and ground our discussion in their language around that topic. Clinical supervision, clinical supervisor models safe and professional communication practices. So we, again, are very aware, cognizant of how we're communicating with everybody, and we're modeling that for the rec therapist the whole time. And also the clinical supervisor advocates for safe organizational culture, which you may have or you may not. It may be something where we're looking at trying to bring about culture change. Trustworthiness and transparency. Clinical supervisor develops trust through authentic and honest interactions. Clinical supervisor explains the purpose of supervision activities as well as inherent risks. We debrief experiences to reinforce the value and goal achievement. And the clinical supervisor admits to mistakes. Again, that might seem like common sense, but we've got to put ego to the side so that we are not losing the trustworthiness, the trust of our supervisees by focusing too much on our own ego. But we want to be as transparent as possible. There may be things organizationally we were told we can't share with our supervisees, and we can tell them there are things that I can't talk about. And so just because of administrative rules, and so I've got to hold that boundary, but I'll be completely honest with you about everything that I can. In terms of peer support, the clinical supervisor recognizes RT staff as experts in their experiences. And we want to promote peer support among our rec therapists or our clinicians, even if it's an interdisciplinary team or multidisciplinary team. The clinical supervisor empowers RTs or the treatment team to encourage each other through mutual self-help towards their individualized goals. And the clinical supervisor encourages peer leadership opportunities. So again, showing that it's not just all about the most experienced or the person in the hierarchy who should be the expert at everything, but we all bring some expertise into this, and we want to emphasize peer support among our staff as much as possible. Which has some crossover with collaboration and mutuality. The clinical supervisor offers equal respect to coworkers in all positions at all levels to promote a collaborative atmosphere. We enthusiastically engage in co-treatment activities with other RTs, actively practicing power sharing during that process. The clinical supervisor creates authentic, informed consent with the rec therapist. So they really know what they're getting into with the clinical supervision process, and no matter what part it is. The clinical supervisor emphasizes RT input in the creation of the supervision plan. And again, we want the supervisee to drive this as much as possible. And as a supervisor, we solicit feedback from the RT. We're not just giving feedback, but we're asking for it. We want to know how effective is this clinical supervision for you. Empowerment, voice, and choice. The clinical supervisor embraces a strengths-based philosophy, believes in resilience and the ability of individuals, organizations, and communities to heal and promote trauma recovery. We teach and cultivate self-advocacy skills. And there may be somehow that the recreational therapist needs to advocate for themselves in other parts of the agency or with clients or what have you, but we're going to cultivate that. And we provide RTs with meaningful choices when possible. So again, those are things that hopefully we're already doing, but it's important for us to also understand these connect directly with trauma-informed principles. And by giving more choices, meaningful choices, that helps us be more trauma-informed as well. But we also recognize cultural, historic, and gender issues. And if the person has similar characteristics to us, we don't assume that they've had similar experiences. But we do know that people may have a different lens based on their lived experience, based on race, ethnicity, country of origin, gender identity, sexual orientation, socioeconomics, education level, etc. So the clinical supervisor strives for cultural competence with their RT supervisees. We do try to understand any issues that are facing them based on demographic or identity-based information. The supervisor honors diverse cultural beliefs and practices. Again, we should be very neutral when it comes to that anyway, but be open, listen to what's important, what are the values of the person that we're working with. And the supervisor believes the RT is the expert on their gendered, racial, ethnic, and cultural embodiment and experiences. So we're not here to question them or to minimize what they're saying based on some of these characteristics. And also, we are guiding as a clinical supervisor. We're always guiding our recreational therapists in working through the RT process with different clients, different issues that come up with it. So we want to be as trauma informed as possible in each step of the APIDE process. You know, that we're dealing with. So we also want to teach trauma informed care principles to our recreational therapists to implement. So we're modeling those in the clinical supervision sessions, but they also should be applying those in their recreational therapy practice. So finally, we've got just enough time. I hope this wasn't moving too fast, but we've got a case study and just a couple notes on bringing issues into clinical supervision. So the case study is going to be the main application. So I've created a fake person here. This is not a real person. Francis is a hardworking RT intern in their 4th week of internship at your agency. At the end of the most recent clinical supervision meeting, Francis shared that they have been experiencing unexpected PTSD triggers within the work setting. Francis didn't mention the original source of PTSD, but explained that during some one-on-one interventions, Francis experienced acute feelings of anxiety when a client would become tense or frustrated and elevated the volume of their voice. So this is new information to you, intern that's kind of in the swing of things, but still in their first part of internship. And so this is what I really would like you to pause, answer these questions. Then I'm going to go over these quickly before we wrap up. But should you ask follow-up questions about previous trauma? What type of recommendations should you make about directly addressing PTSD symptoms? And give 3 examples of how you could infuse trauma-informed principles into your supervision meetings with Francis. And I just bullet pointed those principles down below. So please go ahead and pause one more time. Okay, welcome back. Hopefully you answered all these questions so that we can kind of compare notes now. So the first one, no, you should not ask follow-up questions about previous trauma in terms of what was it? What happened to you? Why were you traumatized? Why do you have PTSD diagnosis? If they volunteer that, that's something that you can hold confidentiality around within your session. Now, if they start sharing personal information that is completely unrelated to the goals, the focus of clinical supervision, their work performance, we need to set some boundaries with that. But you know, we need to move them towards what is relevant. But we should not be prying, asking questions. So that next question, what type of recommendations should we make directly about addressing PTSD symptoms? Now, we should not be acting as a therapist treating their PTSD. We should not be trauma focused in that. But what we should do is think about as a supervisor, you've mentioned that you're having acute anxiety. How are you dealing with that? Do you have some ways to deal with that? Do you have a professional, mental health professional that you're working with on this? If not, you can make recommendations on the types of support that they should be seeking out, starting with resources within your agency. If you know this is an intern, so maybe also collaborating, asking them to collaborate with their university to find out what resources they might have, but making sure that they are connecting with resources and finding the support, but we're not trying to cure them ourselves. And in terms of 3 examples, you might have picked any of these in terms of what you address. We don't know much about their cultural, historical, or gender issues, so that's probably the one that would be the least. But you know, I always start with safety, making sure that they feel safe. I would thank them for bringing this to my attention. and I would want them to feel safe talking about it in the future. I'd be transparent about, um, I'm not going to share this with anybody. However, if this happens, I would have to share this with these parties. But I also might try to encourage peer support. So you're experiencing these like spikes in anxiety when you're working with certain clients. What if you partner with another RT intern and did co-treatments a few times? Or would you like for me to come with you for a few times and we can process together? We can do some co-treats together, but you can decide what that is. But you should feel comfortable bringing any of these things into your clinical supervision meetings. If you are receiving clinical supervision, maybe making a list ahead of time. Uh, but this can be directed by the supervisor or the supervisee. As a supervisor, I think it'd be great if you don't explicitly have trauma-informed clinical supervision right now. Talk to your supervisees about this is a model that I want to use to guide us and guide our discussions, guide the culture of our program and the treatment of clients. So we're going to do some in-service trainings on what trauma-informed care is, the trauma-informed principles, or how we're going to be using this in clinical supervision. Um, but we want to make sure that we're developing clinical supervision pathways and resources that are trauma informed. We're understanding signs of secondary stress and trauma so that we can help our staff address that. But mainly, going down to that last one, using trauma informed care principles as common working vocabulary in our clinical supervision meetings, but every part of our program, which will help make us holistically more trauma informed in the way that we're interacting with people within the workplace. But I know that's a lot of information in a lot of time, but hopefully you're leaving here understanding the basics of what RT clinical supervision is, including what relevance trauma has with recreational therapy, how we can, what the trauma-informed principles are that we can research further, and finally, like what trauma-informed clinical supervision can look like within recreational therapy. Thank you so much for choosing the session. I hope that you will use the information provided to you to reach out if you have any questions or would like to discuss this further. But I hope that you have a wonderful virtual conference, and I hope to see you all sometime in person.